So my name is Jeffrey Barkun. I'm a hepatobiliary surgeon. I happen to have a twin who's a gastroenterologist, so if ever you think you've seen me at a gastroenterology meeting, it's him. And I have a background in epidemiology, and my interest has been primarily in trials. And what I'm going to talk to you about today is how we can put everything together that we have in order to really ramp up the quality of what research we do in hepatobiliary surgery. I have no disclosures. I think most of you are quite familiar with this, which is the pyramid of evidence. It was developed by David Sackett initially when he was at McMaster's University in Canada and then in Oxford. And this pyramid of evidence is really based on how well a given type of study can control for bias. At the bottom, you've got opinions of respected authorities, and at the top, as you all know, systematic reviews of randomized trials. This, however, is only one piece in what is a whole evidence cycle, and the evidence cycle, the phases of evidence-based medicine start from asking a question all the way to answering it as best possible, applying it, and then having a feedback for that. So the natural next question is, how well has this evidence cycle permeated into surgery? And the answer is not as great as we would like. If you take a look at these two surveys, we see strikingly similar results. A group of Australian colorectal surgeons, 200 of them, when they asked whether they were following evidence-based medicine principles in the management of colorectal cancer patients, there were 40% who were really said, no, we don't really do it, and we don't try and go out of our way to do that. A similar survey elsewhere in the globe, in France, based on almost 400 surgeons, showed that 50% of the routine gastrointestinal surgery that was performed by the surgeons was done, again, not based on evidence, even though there was some evidence for that. So you can ask yourself, why is it that evidence-based surgery has not permeated more in surgery? Well, the first is, although randomized trials are the best that we have to offer, when the randomized trial patients that are included in a randomized trial look like this, and your and my patients look like that, you can see that we don't really know what to make with those results. The second one has to do with how robust the way in which the randomized trials were conducted. According to a recent review, it looks like randomized trials, which really should be registered now, in a third of cases are not registered. In almost 25% of cases, they're registered, but only after they're finished, and you got to wonder why. And finally, in about 50% of them, there's a discrepancy between what the primary outcome was supposed to have been when it was registered and what it actually ended up being in publication. And that's really kind of massaging data to a certain extent to fit whatever you want to show, usually a p-value. And it brings to question, well, how well was the rest of the trial done? And for anyone who's been involved in randomization with envelopes that are not opaque, and I'm not saying that it's ever happened to me, but this type of situation brings into question how good the randomized trial is. And I think one other problem that we have, which is inherent in surgery, is what we call treatment preference bias. And in order to explain it, I used an example, and Dr. Bandari was kind enough to lend me a few slides to that effect. This is an orthopedic surgery trial called the SPRINT trial. It's not really important to know what they're trying to do. I mean, they're orthopods. But what they did is 74 surgeons worldwide compared a reamed operation to a non-reamed operation. And before the trial, Dr. Bandari asked the surgeons, do you think that one of the two is superior? Well, it turns out almost 90% of the surgeons said, yeah, of course, the reamed procedure is superior. These are the surgeons who are going to be participating in the randomized trial. Then they randomized almost 1,000 patients. I mean, that's a tour de force. And at the end, he asked the same question, do you think that reamed is superior? And they said, yes, we think reamed is superior. So what's the end result of this? Well, when you read the results of the study, of 510 patients allocated to the reamed operation, 5 received a non-reamed. That's pretty good. But of the 500 allocated to non-reamed, 40 received a reamed operation. And so really there seems to be an asymmetry. And when you're looking at the final results and possible p-values, the main one really that comes out is the fact that there was a major asymmetry in crossovers, suggesting that there's an inherent bias in the study because surgeons tend to be familiar with one procedure, not 2 or 3 procedures. Now, what do authors outside of surgery have to say about this? Well, some have been kind, such as Nick Black in an editorial in the World Journal of Surgery, and some have been less kind, such as Richard Horton, who was and still is the editor of The Lancet, who said, I should like to shame surgeons out of the comic opera performances, which they suppose are statistics of operations. And so the question is, how can we get beyond these comic opera performances? And I would like to propose this afternoon to you a 5-step approach. The first is to adapt the concept of evaluation of new technology to surgery. And I think this is really important for hepatobiliary surgeons because we are probably at the front end of technologically savvy surgeons, both because of the forms of energy that we use and that are inherent in what we do, and also because of the multiple minimally invasive operative techniques which we've brought into our practices. Now, if you look at evaluation of technology, initially it wasn't meant for us. It was really meant for pills. And this goes back to the old days before there was any structure as to how medications were being introduced. And in the 60s, thalidomide changed all that. And what came out of that was what's called the orderly phases of medication development and regulation, which most of you know, which start with microdose pharmacy and end with post-marketing studies. And a medication cannot be released unless it goes through very diligently each of these phases. But that's very different from what happens with surgery, which has been called the neoliberal world. And this is much closer to it. A paper from JAMA which illustrates the introduction of laparoscopic techniques. On this diagram, the axis is the number of years since introduction of laparoscopic technique. The y-axis is the percentage of laparoscopic cases being done, and each curve corresponds to a different type of laparoscopic operation. And what you can see is, depending on how strongly the patients wanted to have the procedure, how strongly the surgeons wanted to do this procedure, and how strongly the marketing from the companies came, you have different slopes and different appearances to all of these curves. But generally speaking, they're fairly similar. And the closest to what they approximate is what's known as a curve of adoption of innovations. Now, this is a curve that had nothing to do with surgery and had nothing to do with medication. It was actually developed and hypothesized in the 60s based on the introduction of grain in the agriculture market in the United States. But it's been applicable to a large different number of areas. So let's presume we're talking about a new operative technique. And let's presume that on the y-axis you have the percent of surgeons who are using it, and on the x-axis you have time. The question that we have then, in order to get out of our comic opera performances, is where do we evaluate the surgery? Because we can evaluate it at any of these points. And also, what do we do when we've passed this so-called tipping point, when any proper equipoise as to whether the new surgery is better or not better than the old one really becomes a moot point because it's already out and the train is already going down and barreling down. So this is the question that was asked by a group of methodologists and surgeons who met 3 years in a row in a dark underground basement in Balliol College. And really what we tried to do, and a number of people in the audience here and part of HPB were involved in this, we tried to balance, on the one hand, patient safety and ethics, and on the other hand, creativity leading to innovation, because we don't want to stifle the innovation. And what we try to do is use science as a way to try and balance the two. And when you try and put it in practice, this is what it looks like. The way it goes something like this. When you have a new technology that's out there, you try and look at what are the patients, how many types of patients are getting the surgery, what are the surgeons, how many surgeons are using this type of new surgery. And depending on the answers to that, you're able to say, okay, well the surgery is probably at one of these levels, going from 1 to 4. And the importance of that is that each of these levels has a proper or more proper methodology to be able to assess the technology of this surgery, which is in the liberal world just going out there, and there's a proper way of trying to get the best way of assessing it. There's also a set of outcomes, which is more appropriate for one stage or the other. So you get a little bit of a template to be able to evaluate what is actually going on. Now, the ideal stages also introduce the concept of this border zone, which is really where you're getting it to the point that a randomized trial is going to be really, really difficult to make. And this corresponds to the tipping point that I showed you on the curve before. But it also insists that randomized trials are the way to go as much as possible. And as we heard yesterday and has been seen, we have yet again in October of this year another example of a randomized trial which puts in question what a number of observational trials have shown, and this is actually duplicated in 2 trials, suggesting that there really is a problem. In this case, the role of laparoscopic surgery in stage 2 or 3 rectal cancer as measured by pathological outcomes. Now, we're not going to be able to do randomized trials for everything. So really, the other question, or the other side of the question, is how can we improve what we do, which best, or most often at least, which is observational studies, or what we'll call non-randomized trials. There's quite a body of literature going back 15 years now, mostly in the medical literature, suggesting that, the results that you get from observational non-randomized studies is not perfect, but it's not that far from what you get with randomized studies. And in 2006, a landmark, what I consider a landmark paper, was published in the Annals of Surgery by Shikata, a huge body of work where he compared the magnitude of effects of non-randomized trials and randomized trials using almost 200 studies altogether and doing meta-analyses where none were present. And what he basically found in this modified forest plot is the results weren't that different. Again, something similar to what had been seen in the medical domain. But there were important conclusions. The first is that there were significant discrepancies in about a quarter of the outcomes between randomized trials and non-randomized studies. The second is that there was a lot of study heterogeneity amongst the non-randomized studies when compared to the randomized trials, and that means that these are studies that the results will be hard to duplicate. They're unstable, and that's not good, because we don't know how far they are from the truth. And the final thing was that the randomized trials they had to compare with were not that great either, and hold that thought because we'll have to come back to it. The second step that I propose in order to improve what we have is to therefore improve these non-randomized trials and improve them at 2 points. The first is the quality of data that we collect. The second is to improve the analysis. The quality of data, before I get to recommendations, I think that the NSQIP and the NSQIP Collaborative is about as high standardized quality data that you will ever have. Now, there are issues with it in that it's only a certain number of variables and you need a certain infrastructure to keep it, but let's keep that in mind, and that's something that may be able to ramp us ahead fairly quickly in our domain of HPB. But in general, for databases and other registries, I think there's a few things that you can do in order to automatically bring up and ramp up the quality of your data. One is a prospective data collection. The reason that's important is that you're not just getting what's available in charts, you have predefined data fields. And the data fields will be the same, predefined the same way for a study group and a control group, say in our area, open surgery and minimally invasive surgery. You're not just happening to get what's available, you're planning it ahead of time. We also need to better describe patients and operations. And the last thing is, although there's a lot of data based on medico-administrative data that are coming out now, there is a problem with those in that often it's not granular enough. And I think we just saw that in Dr. Strasberg's talk upstairs in looking at possibly identifying mechanisms for bile duct injury. You need clinically granular data. And one of the important reasons you need granular data is to get to the next step, which is the actual analysis. Now, you may have heard a lot about propensity studies, and for those of you who don't exactly know how it works, I'll just talk about it in this one slide. Really, it's a complex way of matching patients in two groups, and you use regression techniques basically to recreate what would normally be in a randomized trial, table 1, where you have one group characteristics and the other group characteristics. And the way the propensity matching works, it's regression, so we're used to doing logistic regression, but the dependent variable is the group. And then you have a whole bunch of other variables here. And the big difference between conventional regression, where the dependent variable is outcome, because you're trying to explain outcome, here you're trying to explain the group, and you actually don't care how many variables are there. In fact, the more you can have, the better, because the tighter matching that you'll have. And so it's a very, very powerful technique when used properly. And Isabelle Boutron's group in Paris just published a meta-epidemiological review comparing surgical propensity scored studies to randomized trials. So similar to what I showed you about Shikata for observational versus randomized, but in this case, all the observational actually had propensity scoring. And what you can see in a similar type of analysis is that the results actually are even tighter, meaning that these propensity scored matched non-randomized studies, and randomized studies were actually even tighter. So this is something that's helping to bring us to the gold standard of the randomized studies. They had, however, important considerations, and these had to do with problems with the propensity studies. In up to 80% of the studies, there were key information that was missing in order to be able to say that the propensity was applied properly, and that's a problem. Also, 90% of the studies were based on medical administrative data, as I mentioned to you. And the problem with there is you don't have enough variables that are meaningful to match patients. You have a lot of outcome variables usually, but not enough of the matching patient variables. And the final one is don't oversell the conclusions. They found that in the vast majority of cases, the conclusions were oversold and saying basically it's as good as randomized trials. And the fact is they're not. And the main reason they're not is we don't always know which variables we should be matching patients on, and a randomized trial theoretically will match on these unknown variables also. Another problem that they had is a recurrent theme, again by Shikata and by all the authors I showed you before, commenting on surgical trials from the outside, is that methodology for randomized trials in surgery, still not that great. In up to 50% of cases, it was flawed. Which brings us to the next suggestion I have, which is how can we improve our randomized trials? And the good news is, in the past 5 to 10 years, we have gotten the tools to do that. And it's essentially all these checklists and standards which have acronyms to it, which help with the planning, registration, reporting, and publishing of studies, and in particular are applicable to what we do in surgery. And here are some examples of them. And really, the reason that these are there, the philosophical reason, is that the more information you put in by using these checklists, the more transparent a study will be, the more clear it will be, and therefore, in your mind, you understand what was done. You're actually able to put yourself in the study, suggesting also that you may actually use its results. And I'll only talk about a few of these here. These should be looked at as the techniques that we use in clinical research, similar to the way that we appropriate ourselves techniques which were assays in basic research, bench type research. I think all of you know about the consort statement. It's composed of a flow diagram and a checklist, but this checklist was modified according to 11 points for non-pharmacological studies. That's what we are, non-pharmacological studies. And I'll just show you one example of these 11 modifications, which is over here, suggesting that when applicable, a description of care providers, case volume quantification, expertise, and centers in each group has to be given. When you think back at the MIPR conference we had yesterday, this is starting to make a lot of sense to us because we know that these are variables we want to know about. We have to know about this because it can affect the way we look at the study and the results. And many of these descriptions become very, very important. And what other authors have shown is that the descriptions of drug intervention studies are not bad, but the ones in non-pharmacological interventions, that's us, are very poor. And why it's important also is that lesser control group care may be an explanation for effects that you're finding. I'll give you an example. You go ahead and you do a study of laparoscopic versus open whatever pancreas piece you want to take out, and you don't know if people actually used octreotide prophylaxis. You don't know if drains were removed in the same way or not, and we know that these are very important details which, if they're not given, can affect the outcome. And one of the guides, called the Tidier Guide, actually deals specifically with the description of studies and co-interventions, and it even suggests to add video procedures in an appendix. Again, something that we heard yesterday in a way to try to evaluate and teach the procedures we're doing. So obviously, the authors of all these acronym-based checklists have been listening, and they have something to provide to us. I think one other proviso that I would put in here is it's one thing to try and put all these in the studies, but it's also important, I think, for the reviewers and publication standards to mirror that. And I think there are very few publications right now that expect and insist on these checklists being used, such as consort for randomized trials or the modified consort for no randomized trials. And I think the whole goal is to actually create a surgical culture of clinical research professionalism. Now, the next part that I would suggest, the third of the five-step approach, is to consider what I call lesser-known special types of randomized trials that are really very applicable to surgeons. And one of the not so much used one, but that's very applicable, is the expertise-based randomized trial. This was developed by the group at McMaster's, Benderi, and Devereaux. And what you do is you don't randomize to a procedure, you randomize to a surgeon. And each surgeon is only doing one procedure, which is really what we do in life normally. So when a patient is randomized to procedure A, it means that patient is going to surgeon A to have that operation, and that is the only operation that surgeon A will do, maximizing everything for that procedure. Same thing for surgeon B. And an individual surgeon will not be doing both because they do one best, so let them do that one best. And there are many advantages supposedly to this expertise-based randomization, the main one being what I think is the main disadvantage of conventional randomized trials in surgery is the way to deal with performance bias that I showed you earlier in the orthopedic trial. Another one is called a set wedge randomized trial, which is an example of cluster randomization. And what you're doing here is you're randomizing groups of patients. And you're actually doing a before and after design at each given institution. It goes something like this. You have time over here, and you have different hospitals, 5 different hospitals over here. And what you're doing is you're randomizing when a new procedure will be introduced in which hospital. So you're randomizing that this hospital will get it the first one, this hospital comes second, third and fourth, etc. And you do a before and after with each hospital acting as their own control. Again, this hasn't been used very much, but is suggested for interventional trials, such as essentially what we do every day in surgery. The last one was expanded yesterday a little more by Dr. Fisher, which is the registry-based randomized trial. The idea there is you have an existing registry, so you have patients who are engaged, and you have outcomes that are being measured regularly on patients in that registry. So what you do is you take patients from that registry and you randomize them and you follow it up, and it's thought that it leads to an easier, cheaper randomized trial, and a big advantage is its better external validity because a registry will have less selected patients. The problem is most of the registries we have are surgically based, and if what you want to study is intervention, well then the randomization can't occur. They've already been operated on. The fourth of the steps that I propose is collaboration. Now we know collaboration is good, but I'll explain to you why I think it's even more important, and especially in HPB surgery. The size of surgical trials tends to be small for a whole bunch of reasons. Partly ego of surgeons who want to collaborate, but partly because the diseases that we study are not as prevalent as other diseases in medicine. And why is that important? And I'll just show you a hypothetical example of a small trial and a large trial. In this case, you're measuring mortality. It doesn't matter what you're measuring. There are 2 groups, A and B, and you end up with a relative risk in the large trial, which is 44%, in the small trial, which is 89%, with both of them being significant. And you'd read this and you'd say, well, why do I need a large trial? My small trial gave me my information. Well, over here you've got 100 patients in each group. Here you've got 1,000 in each group. Let's just add 2 deaths to each of the trials. If you add 2 deaths to each of the trials, the large trial pretty much stays the same. But the small trial has the relative risk going from 89 to 57%, and you lose your p-value. And this is the problem inherently with small trials. They're fragile. The results are unstable. And this is what we have to deal with as hepatobiliary surgeons because of the disease we have. And this is why it's really important to collaborate. Now, I'm sure Mark Besselink would appreciate this, but we heard about the LEOPARD-1 and LEOPARD-2 trials, which are randomized trials of minimally invasive versus open surgery for distal pancreatectomy and Whipples, which are going on in the Netherlands, and I congratulate them in getting them going, and I sure hope that this is where we'll end up reading about what's happened to the trials. But there are a lot of other examples of collaborations which have led to major changes in our practice, the NSABP and the way that we deal with breast conservation surgery now, and other examples, such as more recently the CHR-NET Germany effort, where government funding managed to bring in professional infrastructure for 8 regional centers and 320 Kindle partners, and in 7 years they managed to increase the number of randomized patients per year in the country from 1,100 to 7,100. That's a pretty significant improvement. Finally, the last step I propose has to do with outcomes. Now, you'd think as surgeons that we know what we do and we know how to evaluate what we do. I mean, at least complication to complication, perhaps we can have different definitions, but a death is a death, right? Well, not so sure. I put this example, which comes from a systematic review following esophagectomy, where they looked at death. And Dr. Blaisby's group, Jane Blaisby's group, showed that there were 10 different definitions of death. And when they tried to put it together, you couldn't. And really these definitions were definitions which were used because they were convenient for the people who were using them. Now, in HPB surgery, we've done pretty well. We've had some standardization, again, from people who are in the audience today. and postoperative pancreatic fistula, delayed gastric emptying. But those are just isolated things which we're interested in, patients also to a certain extent. They really don't help us classify everything that's going on to the patient, do they? We do have the Clavian-Dindo classification, but I think it's also flawed in the following way. A patient who has pneumothorax gets a 3A classification. Another patient who's got UTI, nausea, and pneumonia gets a 2. And a patient who gets all of them gets a 3A. That means that this UTI, nausea, and pneumonia in this patient really didn't cause any problems to the patient. Well, if you or I are that patient, we'd beg to differ. And that's why Clavien's group has brought out the Comprehensive Complication Index, the CCI, which I find is going to be a way to lead us more to the truth, again, as much as possible. The CCI is scored on a scale from 1 to 100, and it's been validated by multiple groups involved in care, including surgeons, nurses, anesthetists, and patients. There's a website where you have a calculator, and it goes something like this. Examples. In the conventional example of the Clavian-Dindo score, you see over this column, and in the CCI, you see this column. Pneumothorax is 3A or 26. The combination of UTI, nausea, and pneumonia is 30.8, and a patient who gets all of them, as I showed you in the previous example, has 40.5. And you can see that there's a gradient increase in the complications and in the patient's perception as what they're having. So this is, I think, much closer to actually being able to express what the burden of complications is. But the ultimate probably lies in this initiative by Doug Altman and his group, looking at developing core outcome sets for specific types of operations, meaning that if you did that operation, you would be expected to have all of these outcomes included in your paper. And the outcomes that they're promoting also include patient-reported outcomes, measures of functions, activities of daily living, which are very important to patients, and also very important, I find, to elderly patients, which is becoming the majority of the people that we're operating on. So, in conclusion, I think that there are ways to optimize the quality and transparency of what we do by favoring the quality of prospective controlled studies as well as randomized trials. I think that we really need to change our culture and encourage surgeons to do what they've done in basic research, is to become professional researchers. And we have the tools, and the tools are applicable to surgery to do that. And finally, I think that several associations, including this one, have a major role to play in support, knowledge generation, translation, and also bringing groups together so that we're finally able to help stop the comic opera that Richard Horton was talking about. Thank you.